Welcome to PharmaconHealth, your gateway to mastering pharmacology with science, simplicity, and clarity. Paracelsus, the father of toxicology, said it more than 500 years ago, and it is still true today. All things are poison, and nothing is without poison. Only the dose makes a thing not a poison. From the aspirin in your medicine cabinet to the venom of a cobra. From industrial chemicals to contaminated water, toxicology is everywhere around us. In this video, we will build a strong foundation in toxicology, including the basic principles of poisons, how poisoning happens, and the clinical management of toxic patients. By the end of this video, you will clearly understand the definition and scope of toxicology, the dose-response relationship and therapeutic index, toxicokinetics, how poisons move through the body, how toxins cause cellular damage, the clinical management of poisoning using the ABC plus antidote approach. We will also cover 3 of the most important and exam-tested poisoning cases in pharmacology: heavy metal poisoning, organophosphate poisoning, and acetaminophen overdose. These are essential topics for medical, pharmacy, nursing, and health science students worldwide. Let us begin at the very foundation, what toxicology is and the branches it covers. Toxicology is the science that studies the harmful effects of chemical substances on living organisms. It combines knowledge from pharmacology, biochemistry, physiology, and pathology to understand how substances cause harm, at what dose they become dangerous, and how that harm can be prevented or treated. A classic definition from Casarett and Doull's Toxicology describes toxicology as the study of the detection, occurrence, properties, effects, and regulation of toxic substances. A toxin is any substance that produces a harmful biological effect. And one important principle in toxicology is this: every substance can become toxic. The dose determines whether a substance acts as a medicine or a poison. Toxicology is not just one field, it has 4 major branches. Clinical toxicology, our main focus in this video, deals with the diagnosis and treatment of poisoned patients. Environmental toxicology studies how pollutants in air, water, and soil affect human health and ecosystems. This includes substances like heavy metals and pesticides. Forensic toxicology uses toxicology in legal and criminal investigations. It helps detect poisons, alcohol, or drugs in biological samples. And regulatory toxicology sets safety standards for chemical exposure. It helps determine drug safety limits, workplace exposure limits, and food safety regulations. Now, let us explore the foundational principles of toxicology, starting with the most important concept in the entire field: the dose-response relationship. The dose-response relationship is the foundation of toxicology. It explains how the severity of a toxic effect changes as the dose increases. There are 4 key concepts you must understand. First, the threshold dose. This is the minimum dose at which a measurable effect first appears. Below this level, the body's defense mechanisms can usually prevent harm. Second, NOAEL, the no observed adverse effect level. This is the highest dose at which no harmful effects are detected. It is commonly used to establish safety margins. Third, LD₅₀. This is the dose that kills 50% of a test population. It is a classic measure of acute toxicity. And fourth, the therapeutic index. For drugs, this is the ratio between the toxic dose and the effective dose. The same chemical can be harmless in one person and lethal in another. 5 factors determine toxicity beyond dose alone. First, route of exposure. Inhalation is generally the fastest route of absorption for gases and volatile chemicals. Intravenous injection bypasses all barriers. Oral ingestion is subject to first-pass metabolism. Second, duration and frequency. Acute single-dose exposure versus chronic repeated exposure produce very different toxicity profiles. Third, the physical and chemical properties of the agent. Lipid solubility determines tissue penetration. Ionization affects renal excretion. Fourth, individual susceptibility, age, sex, genetic polymorphisms in metabolizing enzymes, nutritional status, and pre-existing disease all modify toxicity. Fifth, chemical interactions. Other substances present can potentiate, inhibit, or be entirely independent of a toxin's effect. Toxicokinetics uses the ADME framework, absorption, distribution, metabolism, and excretion to describe how toxins move through the body. The principles are similar to pharmacokinetics, but with an important difference. In toxicology, metabolism does not always mean detoxification. Sometimes the body converts a relatively harmless substance into a much more toxic compound. This process is called bioactivation. A key example is acetaminophen overdose. At normal doses, acetaminophen is safely metabolized through glucuronidation and sulfation pathways. But in overdose, these pathways become saturated. The excess drug is then shifted to the CYP2E1 pathway, producing a toxic metabolite called NAPK, N-acetylparabenzoquinone imine. NAPK is highly reactive. It binds to cellular proteins in the liver. This triggers oxidative stress, mitochondrial damage, and hepatocyte death. This is the main reason acetaminophen overdose can lead to acute liver failure, not the parent drug itself. Now let us explore how toxins actually damage the cell, the molecular mechanisms of toxicity. Toxins cause cellular damage through 4 main molecular mechanisms. First, oxidative stress. Toxins generate reactive oxygen species, ROS, that overwhelm the cell's antioxidant defenses. ROS damage lipid membranes, proteins, and DNA at the same time. This mechanism is important in acetaminophen toxicity via NAPK, alcohol toxicity, and many heavy metals. Second, enzyme inhibition. Some toxins permanently or irreversibly block key enzymes. Organophosphates inhibit acetylcholinesterase. Lead inhibits delta-aminolevulinic acid dehydratase, disrupting heme synthesis and leading to anemia. Third, receptor disruption. Some toxins mimic normal body signals and overstimulate receptors. Others block receptors completely. Atropine blocks muscarinic receptors. Carbon monoxide binds hemoglobin with about 250 times higher affinity than oxygen, preventing oxygen delivery. Fourth, DNA damage and mutagenesis. Alkylating agents and ionizing radiation directly damage DNA. This leads to strand breaks, cross-linking, and if not repaired, may result in cancer. Now let us move from mechanisms to specific toxins, starting with one of the most clinically important groups, heavy metal poisoning. Heavy metals such as lead, mercury, arsenic, cadmium, and chromium are major environmental and occupational toxins in clinical toxicology. Their importance comes from 2 key properties. First, they accumulate in the body. There is no efficient excretory system for most heavy metals, so they build up in tissues over time. Second, they bind strongly to sulfhydryl, SH, groups on enzymes and proteins. This binding inactivates critical enzymes and disrupts essential cellular functions. As a result, heavy metals affect multiple systems, especially the nervous system, kidneys, and blood-forming organs. Lead poisoning, also known as plumbism, remains a major global public health problem. Now let us go toxin by toxin, starting with one of the most globally significant groups, heavy metal poisoning. Heavy metals, lead, mercury, arsenic, cadmium, and chromium, are among the most important environmental and occupational toxins in clinical toxicology. Their clinical significance comes from 2 key properties. First, they accumulate in the body. The body has no specific mechanism to effectively eliminate most heavy metals, so they gradually build up in target organs with continued exposure. Second, they have a strong binding affinity for sulfhydryl, SH, groups on enzymes and proteins. By binding to these groups, heavy metals inactivate essential enzymes and disrupt normal cellular function. This leads to widespread metabolic dysfunction affecting multiple systems. The most commonly affected target organs are the nervous system, kidneys, and hematopoietic, blood-forming, system. Lead poisoning, plumbism, remains a major global public health problem, particularly in children. Sources of exposure include old lead-based paint, which is the #1 source of childhood lead poisoning. Other sources are contaminated drinking water from lead pipes, occupational exposure in battery manufacturing and smelting, and some traditional medicines. Children are far more vulnerable than adults. Their developing nervous system is highly sensitive to toxins. They also absorb more lead from the gastrointestinal tract, up to 50% compared with about 10% in adults. Lead causes toxicity mainly through enzyme inhibition. It binds to sulfhydryl groups on enzymes and inactivates them. It inhibits key enzymes in heme synthesis, including delta-aminolevulinic acid dehydratase and ferrochelatase. This reduces heme production and contributes to anemia. Lead also disrupts calcium-dependent processes in neurons. This interferes with neurotransmitter release and damages synaptic function. In the developing brain, this leads to long-term neurodevelopmental damage. In children, the most important effect is neurotoxicity. This includes cognitive impairment, reduced IQ, behavioral problems, and learning disabilities. In adults, peripheral neuropathy is common, classically wrist drop. There is also anemia due to impaired heme synthesis. Abdominal colic is common. A characteristic finding is Burton's lines, which are blue-gray discoloration along the gums. Diagnosis is confirmed by measuring blood lead levels. A level below 5 micrograms per deciliter is considered acceptable. Mercury exists in 3 forms, each with different toxicity profiles. Elemental mercury is found in thermometers and dental amalgams. Inorganic mercury salts are used in some industrial processes. Organic mercury, especially methylmercury, is the most toxic form. Methylmercury is highly dangerous because it is lipid-soluble. It crosses the blood-brain barrier and the placenta with ease. It accumulates in the brain and in the developing fetus. A key historical example is Minamata disease in Japan. Industrial discharge of methylmercury-contaminated fish. A fishing community was exposed through seafood consumption. This remains a classic case of environmental mercury poisoning. Mercury exerts toxicity mainly by binding to sulfhydryl groups on proteins and enzymes. This disrupts enzyme function and interferes with cellular metabolism. It also causes oxidative stress and neuronal damage. Methylmercury is especially neurotoxic because it accumulates in the central nervous system. It interferes with neuronal migration and brain development in the fetus. The classic clinical triad includes erythism, ataxia, and tremors. Erythism includes psychiatric symptoms such as irritability, shyness, anxiety, and memory loss. Ataxia refers to impaired coordination and abnormal gait. Tremors are usually fine and intentional. Additional features include sensory impairment, visual field constriction, and cognitive decline. In pregnancy, exposure can cause congenital neurological defects in infants. Diagnosis is based on laboratory testing. Urine mercury levels are used for inorganic mercury exposure. Blood mercury levels are used for methylmercury exposure. Mercury poisoning primarily affects the nervous system, kidneys, and the developing fetus, and damage may be irreversible. Arsenic poisoning is a major global public health problem. Contaminated groundwater in regions such as Bangladesh, India, and parts of sub-Saharan Africa affects hundreds of millions of people. It is also a classical toxicology condition. Inorganic arsenic is the most toxic form. Arsenic primarily disrupts cellular energy production. It inhibits the pyruvate dehydrogenase complex and the succinate dehydrogenase complex. This blocks the Krebs cycle and oxidative phosphorylation. As a result, cells are unable to produce ADP, leading to cellular energy failure. Acute arsenic poisoning typically presents with severe gastrointestinal and systemic symptoms. There may be a garlic-like odor on the breath. Patients develop burning abdominal pain and profuse watery diarrhea, often described as rice water stool. Severe cases progress to dehydration, shock, and cardiovascular collapse. Chronic arsenic exposure, also called arsenicosis, develops over time. The classic skin findings include a triad. Hyperpigmentation of the skin. Hyperkeratosis, especially on the palms and soles. Mies lines, transverse white bands on the fingernails. Long-term exposure is carcinogenic. It increases the risk of skin cancer, lung cancer, and bladder cancer. The definitive treatment for heavy metal poisoning is chelation therapy. Chelating agents are molecules that bind metal ions tightly and form stable complexes called chelates. These complexes are then eliminated from the body through urine or bile. Chelation therapy helps reduce the body burden of toxic metals and limits further tissue damage. EDTA, ethylene-diamine tetrashic acid, is a first-line chelator for symptomatic lead poisoning. Dimercaprol, also called BL or British anti-leucite, was originally developed as an antidote against arsenic-based chemical warfare agents. It is used in poisoning from arsenic, mercury, and sometimes lead. Succimer, also known as DMSA, is an oral chelator used for mild to moderate lead and mercury poisoning. It is especially useful in children because it has a lower toxicity profile. D-penicillamine is used to chelate copper in Wilson's disease and may also be used in gold poisoning. Deferoxamine binds iron and is the treatment of choice for iron overdose. Chelation therapy is most effective when started early, before irreversible organ damage develops. Now let us cover one of the highest yield topics in clinical toxicology, organophosphate poisoning. Master this, and you will ace any pharmacology exam on it. Organophosphates are commonly found in agricultural pesticides such as malathion, parathion, and dichlorvos. They are also present in military nerve agents like sarin and VX. These compounds cause toxicity by irreversibly inhibiting acetylcholinesterase. Acetylcholinesterase is the enzyme responsible for breaking down acetylcholine in the synapse. When this enzyme is blocked, acetylcholine accumulates at all cholinergic synapses throughout the body. This affects muscarinic receptors in smooth muscle and glands, nicotinic receptors at the neuromuscular junction, and cholinergic synapses in the central nervous system. The result is a severe cholinergic crisis, sometimes called a cholinergic storm. A critical feature of organophosphate poisoning is a process called aging. Over time, the bond between the organophosphate and acetylcholinesterase becomes permanently fixed through covalent binding. Once aging occurs, the enzyme can no longer be reactivated. This is why pralidoxime must be given as early as possible before aging develops. The clinical presentation of organophosphate poisoning is best remembered using two important mnemonics. For muscarinic effects, involving smooth muscle and gland stimulation, remember DUMBLES. DUMBLES stands for defecation and diarrhea, urination, meiosis, constricted pupils, bradycardia and bronchospasm, emesis, vomiting, lacrimation, excessive tearing, salivation, and sweating. These symptoms occur because of excessive stimulation of muscarinic receptors. For nicotinic effects at the neuromuscular junction, remember the 3Ps. Paralysis, fasciculations, and pulse increase, meaning tachycardia due to nicotinic ganglionic stimulation. Central nervous system effects include anxiety, tremors, seizures, loss of consciousness, and eventually respiratory failure. Respiratory failure is the most common cause of death in organophosphate poisoning. A classic bedside clue is the combination of meiosis and excessive secretions. If you see a patient with pinpoint pupils who is drenched in secretions, think organophosphate poisoning immediately. Management of organophosphate poisoning follows a clear stepwise approach. First, scene safety and decontamination. Remove the patient from the source of exposure. Contaminated clothing should be removed immediately. The skin should be washed thoroughly with water. Healthcare workers must use protective equipment because organophosphates can be absorbed through the skin. Second, stabilize the ABCs, airway, breathing, and circulation. Ensure the airway is open. Provide oxygen and respiratory support if needed. Treat seizures promptly. Third, atropine. Atropine is the antidote for muscarinic symptoms. It is a competitive muscarinic receptor antagonist. Atropine reverses symptoms such as salivation, bronchospasm, lacrimation, bradycardia, and excessive secretions. The treatment endpoint is drying of secretions and improvement of bronchospasm, not pupil dilation. Atropine does not reverse nicotinic symptoms such as paralysis or fasciculations. Very large doses may be required in severe poisoning, and dosing is titrated according to clinical response. Fourth, pralidoxime, also called PM. Pralidoxime reactivates acetylcholinesterase before aging occurs. It must be given early, usually within hours of exposure. Unlike atropine, pralidoxime can improve nicotinic symptoms and some central nervous system effects. Now let us walk through the most important clinical management framework for any poisoning. The universal approach every clinician must know. The approach to any poisoned patient follows a universal stepwise protocol. First, immediate resuscitation. Assess and secure the airway. Ensure adequate breathing and support oxygenation if needed. Establish circulation and stabilize the patient. This always takes priority over identifying the toxin. Second, history, and exposure assessment. Determine what substance was taken, how much was taken, when exposure occurred, and by which route. Check whether any medication containers, chemicals, or samples are available for identification. Third, clinical examination. Look for toxidromes, characteristic clusters of signs and symptoms that suggest a specific group of toxins. The cholinergic toxidrome includes meiosis, bradycardia, and excessive secretions, suggesting organophosphate poisoning. The opioid toxidrome includes meiosis, respiratory depression, and reduced consciousness, the classic opioid triad. The sympathomimetic toxidrome includes dilated pupils, tachycardia, hypertension, and hyperthermia, commonly seen with cocaine or amphetamine toxicity. Fourth, investigations. These may include toxicology screening, blood levels for specific toxins, liver function tests, renal function tests, and ECG monitoring. Fifth, specific management. This includes decontamination, administration of antidotes, and enhanced elimination techniques when indicated. Decontamination aims to prevent further absorption of the toxin. Four techniques are used, each with specific indications. Activated charcoal, the most commonly used decontamination agent, adsorbs toxins in the GI tract, preventing their absorption. It is most effective within 1 to 2 hours of ingestion. It is not effective for iron, lithium, alcohol, or caustic agents. It requires an intact airway. Never give to a patient with reduced consciousness without securing the airway first to prevent aspiration. Gastric lavage, stomach washout, is now rarely performed due to risk of aspiration and lack of evidence for most poisonings. If used at all, it should be within 1 hour of ingestion. Whole bowel irrigation with polyethylene glycol is used for ingestion of sustained-release drug formulations, iron tablets, and drug packets. Body packing. Skin and eye decontamination, copious water irrigation, is essential for dermal or ocular chemical exposure and must be started immediately. Knowing the major antidotes is extremely important in toxicology and clinical medicine. Opioid overdose is treated with naloxone. Naloxone is a competitive mu-opioid receptor antagonist. It rapidly reverses respiratory depression, sedation, and meiosis. Because naloxone has a short half-life, repeated doses or continuous infusion may be needed for long-acting opioids. Acetaminophen overdose is treated with N-acetylcysteine, also called NAC. NAC replenishes glutathione stores and helps detoxify NAPQI. For best results, NAC should ideally be started within 8 to 10 hours after ingestion. Treatment decisions are guided using the RUMAC, Matthew nomogram. Organophosphate poisoning is treated with atropine and pralidoxime. Warfarin overdose is treated with vitamin K for reversal. In severe bleeding, fresh frozen plasma or 4-factor prothrombin complex concentrate may be required for rapid correction. Digoxin toxicity is treated with digoxin-specific antibody fragments, also called digoxin Fab. These antibodies bind digoxin directly and remove it from receptor sites. Benzodiazepine overdose may be treated with flumazenol. However, it must be used cautiously because it can trigger withdrawal seizures in dependent patients. Iron overdose is treated with deferoxamine. Carbon monoxide poisoning is treated with 100% oxygen. Severe cases may require hyperbaric oxygen therapy to rapidly displace carbon monoxide from hemoglobin. Now let us apply everything in a structured case study. Acetaminophen overdose, the most common drug overdose presenting to emergency departments worldwide. Clinical case. A 22-year-old woman presents to the emergency department 6 hours after intentionally ingesting 20 grams of acetaminophen, about 40 standard tablets. She is nauseated, has right upper quadrant pain, and her liver enzymes are rising. What is happening? At therapeutic doses, acetaminophen is safely metabolized by glucuronidation and sulfation. In overdose, these pathways become saturated. The excess drug is diverted to CYP2E1, producing NAPQI, N-acetylbenzoquinone imine, a highly toxic metabolite. NAPQI rapidly depletes hepatic glutathione. When glutathione falls below critical levels, NAPQI directly damages hepatocytes, causing centrilobular necrosis and acute liver failure. The clinical course progresses through 4 stages. Stage 1, within 24 hours, nausea, vomiting, malaise. Stage 2, 24 to 72 hours, apparent improvement, but liver enzymes continue rising. Stage 3, 72 to 96 hours, peak liver injury with jaundice, coagulopathy, encephalopathy, and possible liver failure. Stage 4, recovery or death. Management begins by measuring the serum acetaminophen level and plotting it on the RUMAC methanogram. Activated charcoal may be used if presentation is within 1 to 2 hours after ingestion. The antidote is N-acetylcysteine, or NAC. NAC should be started immediately, ideally within 8 hours, though benefit may extend up to 24 hours. It replenishes glutathione and helps detoxify NAPQI. Monitor liver function, INR, and renal function closely. Severe cases may require liver transplant evaluation. Let us close with prevention strategies and the emerging future of toxicology, and then our definitive summary. Preventing poisoning operates at 3 levels. Primary prevention focuses on stopping exposure before it occurs. This includes child-proof medication packaging, safe storage education, occupational safety regulations, and limits on chemical exposure. Secondary prevention focuses on early detection. This includes poison control centers, toxicology screening programs, and monitoring heavy metal exposure in high-risk populations. Tertiary prevention focuses on reducing harm after poisoning has occurred. This includes rapid access to antidotes, toxicology specialist consultation, and post-exposure counseling. An important clinical point: poison control centers are extremely valuable resources. They provide immediate expert guidance for both clinicians and the public. In complex poisoning cases, they should be contacted early. 3 emerging trends are transforming toxicology. First, pharmacogenetics. Individual genetic variation in CYP enzymes, glutathione S-transferases, and other metabolic systems explains why some people are more susceptible to toxins than others. Pharmacogenetic testing may allow personalized risk assessment for toxic exposures in the future. Second, artificial intelligence and machine learning in toxicology. Algorithms can now predict toxic effects of new chemical compounds from molecular structure alone. This reduces reliance on traditional testing and accelerates safety evaluation of new drugs and industrial chemicals. Third, novel antidotes and targeted therapies. Early examples like digoxin-specific antibody fragments showed the potential of targeted toxin neutralization. Now, monoclonal antibodies and RNA-based therapies are being developed for a range of toxins, including synthetic opioids and emerging chemical threats. Together, these advances are shifting toxicology toward more predictive, personalized, and targeted approaches. Let us bring everything together in our definitive clinical summary. Your definitive clinical summary of toxicology. The dose makes the poison. The dose-response relationship is the foundation of all toxicology, defining threshold dose, NOAEL, and LD₅₀. Toxicokinetics applies ADME to toxins. Critically, metabolism can produce more toxic metabolites through bioactivation, as seen with NAPQI from acetaminophen. Heavy metal poisoning. Lead causes wrist drop, anemia, and Burton's lines in adults and cognitive impairment in children. Mercury causes the erythism ataxia tremor, triad, and bioaccumulates through the food chain. Arsenic causes the garlic breath rice water diarrhea, acute presentation, and the hyperpigmentation hyperkeratosis Mies lines chronic triad, all treated with chelation therapy. Organophosphates cause cholinergic crisis via irreversible inhibition, dumbbells for muscarinic, fasciculations for nicotinic, seizures for CNS. Treat with atropine for muscarinic and pralidoxime early for nicotinic and CNS effects, before aging locks the enzyme. The universal poisoning framework: resuscitation first, then history, toxidrome recognition, investigations, decontamination, specific antidote. Know your antidotes: naloxone for opioids, NAC for acetaminophen within 8 hours, atropine plus pralidoxime for organophosphates, vitamin K and PCC for warfarin, digoxin fab for digoxin, deferoxamine for iron, 100% oxygen for CO. If this video has strengthened your understanding of toxicology, from Paracelsus to pralidoxime, please subscribe to PharmaconHealth and share it with your colleagues, classmates, and clinical teams. Thank you for learning with PharmaconHealth, where pharmacology protects lives.